Finally, we have a hot topic tonight, and we are so excited to welcome the city's new director of the Department of Behavioral Health and Mental Health SF, Dr. Hillary Kunins. So I always like to make sure I'm pronouncing names correctly. And so she went over it with me. So it's good to get the head nod that I got it right.
Okay.
Excellent. So how are you doing?
Well, I'm doing okay, a little nervous with all you folks looking at me. New city, new job, and hopefully tail end of a pandemic. So I'm coping.
All right, so one of the things you being a New Yorker who has moved, you finally settled with the bagels. Because everyone was, I think the New York Times had an article about the best bagels. If anyone's from the East Bay, have you tried boy chick bagels yet? Woo! All right, yes, it's working well. Have you tried one? Okay.
But I'm super excited to have made this journey across the continent to work on I know what are pressing and really critical issues here.
So it sounds like you were doing a lot of heavy but exciting stuff. So what prompted your decision to say, thank you, de Blasio, I'm out?
That's a great question. Some of which is private. I grew up in and around New York City. I've spent my whole professional career there, including I should just also add I'm a physician and I'm an internal medicine physician by training, which means I got to learn how to take care of people's high physical health needs, high blood pressure, diabetes, aches and pains. And I ended up training in the Bronx, and specifically the South Bronx, which I think is quite famous, is a place that has had really a long history of disinvestment, disenfranchisement, racism, criminalization of large swaths of folks who live there. And it is a fantastic city, and I grew to love the Bronx and the city as a whole. And I think of the challenges that are facing us nationally, not just here and not just in New York City, some of the challenges in New York are issues of bigness, about how large of a population it is, how much control and authority is split among city and state, or county and state. And one of the enormous opportunities that I think we have before of us, all of us, is that we are a city that we can get our arms around. We can know each other. some of those lines of authority, I hope, are less split, and so we can take action as a municipality and county that weren't always possible, in my view, in New York City.
So that actually ties into talking about the scope of what you do. I think a lot of times when we have these huge, seemingly intractable issues and someone is given the title director, everyone's like, oh, you're responsible for all of it. So tell us a little bit, first off, just, I don't know about you all, but what is behavioral health?
So it's a great question, and I think like a lot of healthcare and medicine, we use an awful lot of jargon, so I really try not to. So the term behavioral health has come to mean health issues related to mental health diagnoses or conditions, or substance use, addiction related conditions, to kind of try to cast a broad net. In part, it's a response to a long-ish history of those two problems being separated into the treatment systems that address them. And this may be familiar to some of you. You can show up at one door and they're like, oh, we only treat your mental health problems. And you show up at another door, oh, we only treat your substance use problem. And I think the term is really meant to convey a commitment to trying to unify approaches and create integrated care. So that's part of your question.
Yes, and so is that the purpose of the mental health SF initiative? And can you tell us a bit about that?
Sure, and let me say one more word about behavioral health just for people to be aware of. In this country and in this state, as I am learning, the county governments are often responsible for behavioral health care in that county. And there's the funding streams work that way, and the licensing and regulatory stuff gets passed down through the counties from the state to basically overlook a system of care which for many years has been siloed, stigmatized, separated from the mainstream of healthcare for all kinds of reasons. And so all over the country, including here, there are, by and large, most counties, directors of behavioral health. And their role is often to overlook the safety net behavioral health system. And so that is sort of part of what I am part of. There are some problems with that model, but let me answer the mental health SF part first. So as I understand it, and I'm walking into some inheritance here, mental health SF was legislation passed by the Board of Supervisors in 2019 that had some very specific focus areas and subsequent funding to really address what was seen as the major problems and gaps in how the behavioral health system of care and how the approach to people with serious mental illness or substance use problems was, or I think as many of you see and feel, wasn't working. And so the idea behind the joint job is to really bring together policy and strategy and proactive responses along with this older kind of division of care under this rubric behavioral health or county behavioral health authority.
So do you sometimes feel like your job as director is hurting cats?
Yes. And this is both the annoyance of working in government and the fabulousness of working in government. If I'm sort of listening to Manny say, oh, we're a small business and we're a not-for-profit business, and it's probably pretty easy to move and change because it's nimble and responsive. And one of the things about government is indeed herding cats, pushing agendas, trying to make change, trying to do the right thing, trying to be responsive to constituents and people who are that I essentially am working for, all of you, and it can be Herculean.
So to put on top of that, as if that wasn't enough, you started in March, right?
March 29th, so late March.
So,
this year, not the year that the pandemic began.
but you mix in, you moved across country, you took on a new job that you just described basically as Herculean in its responsibilities. In the middle of a wave, I've lost track of the number of waves, but another wave of a pandemic, what has that been like?
So it's been, I'm always up for a big challenge. It's been hard, but it also, the themes and both the themes and the challenges and the opportunities are not so different from what I was doing all the way across the country. I do this work because I feel impassioned about it and optimistic about it. And it is at the center of important, meaningful change, I think. And so it's been hard, and I think, for all of your collective San Franciscans, it's a lovely city to move to. People are extremely nice and welcoming. We'll just leave the other part unsaid about New York, where people are not less nice, but also very welcoming. I want to say, should any of you decide to visit that. But it has been, and it's a city that I have known over many years, just to say, through close friends and many visits. So
Because I was gonna ask, I would imagine in a time like this, you're already starting to enroll, it's so important to have some sort of support network in place.
And I do have some lovely old friends here with whom I am delighted to be on the same coast with.
Excellent. All right, so let's kind of dive in. Are you ready?
I'm ready.
Okay, you got like strong shoes on, so I'm very confident. All right, we both have like the texture, it's so serious. So how would you define the problem that you've been tasked to resolve or address?
So I think sort of if you think about sort of a pyramid or an iceberg maybe sticking up out of the water, I think what is very visible and very much felt, including by myself, is the experience of walking around San Francisco and seeing lots of folks on the street who are unhoused, who some of whom appear to have mental health problems or substance use problems. And that is certainly part of what we, DPH, and I am being asked to respond to and to fix, resolve. And that problem that is visible, I think, to everybody who lives here, sort of belies underneath, sort of, I think, and I would offer other challenges that we are having as a community, as a society around mental health and well-being. And things like, and I think it's very clear that the pandemic has, like it has exposed and reinforced racial disparities in death and illness. It has also exposed sort of dis-ease, mental, maybe not frank illness, but not feeling so well emotionally, disconnection, and that those experiences are not felt equitably and across society. So while I'm addressing urgently, and we are trying to address urgently these very visible part of the problem, an additional part of what we are seeking to do is work on population and emotional well-being for the population as a whole as well.
So in the time that you've been here, obviously you've had a chance to sort of survey, get a lay of the land. What would you say San Francisco has been doing right?
So there's so many strengths here, and partly what attracted me to come here is that it has a foundation that can be built upon. There are some parts of the country, and I'll speak about the overdose epidemic first, where there are no treatment systems, where there is no access, simply not enough providers of addiction care. There are lines for one of the most effective forms of treatment for opioid addiction, methadone, where many, many counties simply don't have that. This city was an early adopter of harm reduction approaches and access to syringe exchange, in large part driven by HIV and AIDS activists. And that foundation and overall acceptance is here. Doesn't mean it's enough across all the kinds of things that we're doing. Doesn't mean there's room for innovation, which I think that there really is. But those foundational elements and city commitment to devote resources, both historically and new resources, is extraordinary. There's also a world-class medical center, as you likely know, and one benefit from that world-class medical center is there are health professionals who want to come work here and stay here and really deliver very, very high quality care.
So then on the flip side, again, as you surveyed, what are some of the things that you found that haven't worked?
So I think one of the challenges, and this is similar to my experience in New York, is in a high cost city, in a high cost region, fundamental issues around housing really drive health outcomes. And sort of the lingo increasingly in health worlds is housing is healthcare. And sometimes, and maybe even many times, without housing, we can't really help people achieve better health outcomes. And so that is a challenge here. I was certainly expecting it, and what is very heartening both at the city and state level is it is very clear to be top priority, high, both at the city and state level, for one of the things that we must resolve in order to see change happen. I'll just add another sort of statewide challenge here is, as a country, we move towards what became known as deinstitutionalization of people with serious mental illness. There is no question that the institutions that we had for people with serious mental illness were terrible places, were dehumanizing, were overly restrictive, were unethical, and the promise of that movement was that we would build up community mental health and be able to absorb folks coming out of essentially hospital level of care. I see some shaking heads who agree, but that promise never was fully realized. And we are in large part as a field, as a city, living out the consequences of that failed promise. What is specific about California, to what I'm observing, and there may be others in the audience who know this better than I do, is that access to inpatient or that psychiatric hospital level of care is worse even here than certainly my experience of New York. And that is another challenge I was not fully expecting.
And that actually ties in, I think, because there was this gap, that vacuum has been filled with wide infrastructure of service providers and stakeholders and policy leaders, and like so many people with different little fiefdoms, if you will. And I wonder, what's it been like for you to navigate that? Have they been a support or a hindrance, and have you been able to cut through?
So what's part of my job, or I see as part of my job, is speaking to as many of those folks as I possibly can. Partly I am very much still learning the landscape, and partly, and this comes from my background as a clinician for many, many years, taking care of patients directly, is folks providing services, directly providing care, are living out experiences, whether they're policy challenges, operational challenges. And so I guess I would just frame it slightly differently, as part of my responsibility is to know what they're thinking and experiencing. And part of my responsibility is to try to synthesize all voices to move policy or move programs forward. For those of you who might be interested, for example, we did this today, have a monthly implementation working group that is open to the public virtually at this point, that reviews the many things that we are trying to accomplish in mental health SF. There is room for public comment. The committee members were appointed by a variety of bodies, and it's very much democracy in action. There's a lot of democracy here in San Francisco, and it is lively and I think really important.
And those are every month?
Once a month.
Okay.
And they're called an implementation working group, and we can, I'm sure, get you the link or how people can tune in.
So I think that's one of the questions that's come up as we, have been talking through this, just talking with sponsors and supporters of the space. A lot of people want to know the how, the what's happening. I think there's a bit of exhaustion around we have this problem because it's not brand new. So how are you, I really appreciate hearing that the public is invited to that. How are you navigating the public conversation around this?
Well, this is one of my very first public appearances, so we'll see how that goes. And you'll tell me after how I'm navigating. I think, as I've talked to, I've mentored and taught a lot of health, future doctors, future other health professionals. And I think sometimes you think, oh, government is really far away. Maybe it feels less far away here in San Francisco because it's a smaller town, but it's our job as people in government to listen to what the public says. And so and sometimes we can disagree, and I hope we can, sometimes agree to disagree. I think what is specific is trying to balance so many very strong voices, sometimes who have really opposing views. And sometimes when we're making judgments in government about what's the right thing, we're sort of saying, okay, this is what we think is going to work, and we're going to try it. And hopefully we're humble and nimble enough to say, okay, maybe this is not the best approach. We've got to shift gears. So I guess I kind of sometimes meet people's vociferousness with, how do you know that that's going to be what works? Because maybe I don't. Tell me what you know and how you know it. And this is maybe the scientist in me, right? Sometimes we don't have scientific evidence and we have to make the best decision at the moment. Sometimes we do have scientific evidence and people still make a case for why that's wrong. And that's can be challenging. And I think part of my job is to explain what I know scientifically, what's been shown in studies, and try to make the case and convince people that this is the right way to go.
I highly recommend meditation.
Meditation.
Here in the Bay, there are tons of ashrams and meditation circles. I got recommendations.
So this is the New Yorker being like, I don't know about this slowing down business.
So before we move on, regarding that implementation, you mentioned, talk about the top priorities. What are, say, the top 3 priorities for that?
So what that group does, and what the top, some of the top priorities for mental health SF are, again, and you can read about this in the legislation, are expanding, as we have come to call it, residential care and treatment. And so building out, whether it's by contracting or directly building, new residential care. As I mentioned, lots of people agree that that is a big problem. That mental health SF funding is providing for 400 new beds of a variety of approaches that will get built out in the coming years. We've already opened or will soon open some of those beds. There is a more intense kind, for example, called locked subacute treatment for folks that are very, very serious, have very serious conditions. We are going to be opening what has come to be called Soma Rise in the winter this year. That is, so on another end of the spectrum, what we call in sort of the jargon of the field, low threshold drop-in spaces for people who are intoxicated, originally designed for people intoxicated with methamphetamine, but now, but it will be welcoming to whomever as a safe place to come down, get material needs met, food, shower, and importantly, to establish trust and engagement with health professionals and linkage to ongoing care. So those are just two examples. That's one priority. Another area that is high priority, which I hope you have seen around town, street crisis response teams. These are the very spiffy looking red vans that respond to behavioral health crises in the street without law enforcement. The multidisciplinary teams include a behavioral health clinician like a social worker, somebody with lived experience or a peer worker, and a special branch of EMTs, EMS 6, who are community paramedicine trained, and they respond to people on the street. So those are some of the things that you might hear about discussed in a lot of detail during those implementation meetings.
Have you been able to expand that street outreach?
So that street outreach, it's really very exciting, and this has certainly made national news as well as local news, and really is being held out as a model for the country. It is now working 24/7 across the city, responding to calls that come in through 911, but when they are triaged to be a behavioral health crisis call, that team is sent out to respond.
And I guess it's an interesting question because, you know, at least what I've read when people talk about the encounters on the street, a lot of times they involve repeaters, if you will. So are you finding that having these street teams and being able to expand the number of street team participants, is it making a difference? Are you seeing repeaters across?
Well, let me answer in a slightly different way, which is part of our goal is we want to prevent unnecessary arrests or law enforcement involvement or emergency department transfers. What we want to do is guide and link people into other kinds of therapeutic interventions and the possibility of more long-term or longitudinal intervention. So if I guess I would say, and I don't have the number in my head, I am guessing we do see people more than once. We don't necessarily consider that a failure. We consider that as another opportunity to engage. If we can allay the situation, prevent the crisis, or reduce sort of whatever's going on, and ideally link the person to something, whether of their choice. So, for example, I'll just mention Soma Rise. When that opens, that will be a place that the teams can bring people. Right now, there's another site open called Hummingbird, which is on Valencia that way, by about 10 blocks. Also a low threshold psychiatric respite space. So these are examples that in partnership with the street crisis, we must also build out other kinds of services that can address people's needs, get them off the street, provide them more definitive or long-term care.
So you have an interesting job. You are leading a team that knows how many people who are tasked with going out and offering care, trying to help people be better, if you will. But I imagine you have a lot of people who aren't receptive. So what are those frustrations? Like, what are the hurdles that you encounter giving or offering that help to people who
Yeah, I think that this is sort of the core work of behavioral health providers. And as an addiction medicine doc for many years, again, as I referred to in the South Bronx, I worked with some of the same patients over more than a decade. And so I had the opportunity, which I think is obviously not usual, to see people grow and change over time. And so what our experience walking on the street by folks who we sometimes see every day, who maybe we don't feel so optimistic about their possibility of change. As a physician, again, in a methadone maintenance program in the South Bronx, I saw people who started out looking like some folks that we might see on the street around here, who end up in apartments with jobs, with partners, and it's extraordinary. It's extraordinary, and that is the hope and optimism that I've seen firsthand that I would like to convince all of us about. But there are definitely frustrations, because as a health professional, when you know someone is hurting themselves, not doing the things that could keep themselves safer, it can feel frustrating. It can feel, you could get mad. You can be like, what's wrong with them? And that is the complexity, as we all know, of human behavior, and in particular, the diseases of mental illness and addiction. So both of those things are true.
So I wonder, do you feel like this can never be fully solved?
So I think I would probably be naive to say it could be fully solved. I think these very serious problems of mental illness and addiction will always be with us. I think what we know from science and from studies is that if we build supports, including importantly housing, including importantly treatment that is proactive and flexible, we can help people do better, a lot better. And I think we can look a lot different as a system of care, which is what I am in it for. And I think we can do better, a lot better at a city level in creating policies that support our neighbors and support particularly our neighbors who are experiencing addiction and mental illness. And I think we see pockets of this across the country, including here, in the shape of well-run supportive housing with good behavioral health supports, in the shape of syringe exchange programs with wraparound mental health and other physical health services, in the shape of, in my own experience, methadone programs with co-located primary care, vocational services, and peer-led service navigation. So I have seen models that work, and I think that we need a collision of multiple social and municipal policies to work together, to all be going in the same direction. I think the moment is here now. Obviously, I hiked across the country to come do this, but I really think that we have a chance, and I think we have a chance here in San Francisco.
So just a couple more questions and we'll turn it over to the audience. So another thing that's very novel, you mentioned innovation earlier. Thanks to Proposition C, there is a buttload amount of money available for this. I believe I read 600 million. And when you were in New York, you were working with a program where the budget was 60 million. So this is a lot. Do you have, with that, I presume comes a lot of responsibility, a lot of expectation. Are there benchmarks that you are setting for the program? And if so, what are they?
Absolutely. And so let me just say another word about Prop C, which folks may not be familiar with. So Prop C is a local taxpayer-backed initiative to fund particularly housing and particularly housing that supports people's mental illness and substance use. So that money was only part of it is coming to the Department of Public Health. It's more like 90 million. And so part of that money got dedicated to behavioral health interventions and supports. So a lot of what I am describing or described in mental health SF is being funded by Prop C money actually. And so there will be benchmarks sort of across all of the Prop C funded initiatives in the shape of a dashboard that goes up on the city page, on city pages. I'm not sure the timing of that, as well as specific DPH behavioral health specific work. We are very, as you're hearing, very busily have started up a number of new initiatives and will continue to move forward aggressively. There's another, and that Prop C work, speaking of sort of public participation, is overseen and directed by another important committee, Our City, Our Home, with whom the health department and other city agencies really participated in a budgeting and allocation process that, for me, coming from New York, was really fantastic to get to participate in. So I invite all of you there for more information as well.
And how do you define success for yourself in this role?
So we haven't mentioned overdose so much now, but I'll just speak about that also. I think our success and my own success is seeing a well-coordinated, seamless behavioral health system of care that provides ready access, connections between levels of care, whether it's residential or low threshold, that helps people with serious mental illness live longer and healthier lives, and importantly, tackles overdose deaths. And I do want to just say that overdose deaths, because we didn't get to spend so much time on it tonight, are epidemic right now in San Francisco. It is, in particular, I want to call out the fact that Black African Americans in San Francisco are dying at 4 times higher rate than other San Franciscans. This is a tragedy, and we can do lots of stuff to deal with it, and we are. And so another measure of success is driving down that overdose death rate and reducing, in particular, racial disparities in those overdose deaths. And that is an additional marker of success for myself.
I appreciate you bringing that up. I intended to ask about that, but this is such a huge task or a series of tasks. So thank you so much for incorporating that in and saying that that is one of your measures of personal success in the world. I think that's really cool. So with that, I could go on. We already talked about us having curly hair and all the things, but I know you all are here and have your own questions. So who would like to get it started? The gentleman with the beaver?
Cheshire cat.
A Cheshire cat mask. Okay. And what else? Say it kind of louder, then I'll repeat it for our Zoom audience.
I'm actually a critical care ICU nurse, and I work with this population on a daily basis. So almost all the street drugs are laced with fentanyl, and the overdoses are happening with fentanyl overdoses. And I know that the lack of enforcement of the drug dealers and the typical is kind of being overlooked instead of actually enforced. How do you feel, and how can we change that where at least the drug dealers can at least reduce some of the drugs going into that population?
So the question was talking about the enforcement against drug dealers, specifically in the Tenderloin, but just more broadly, and what can be done to reverse that lax enforcement.
So I'm going to respond as a public health official, which is that what I do know is we have had a long history of attempting to stop drug supply in our country. And we probably, many of us lived through the crack cocaine epidemic. Some of us may have lived through the first heroin epidemic, and we were not successful as a country in focusing on interdiction or interrupting supply. So I would defer I think you're raising really good points, which is the availability of fentanyl in our city is certainly driving overdose deaths. So what is our collective response to that? On the public health side, many approaches to enforcement historically have not been successful. So what we focus on in public health is strengthening in every way possible health-oriented responses. That includes early prevention with kids and middle school and high school students that are not around, as we all, or some of us remember, just say no, but approaches, in fact, that build skills, that strengthen social support, that strengthen family ties. These are all other kinds of prevention approaches, including easy access to effective medication, including now access to emergency medication like naloxone, which is the reversal medication, including addressing people's underlying trauma, which drives people's risk of substance use, and I could go on. So I know that there's a lot of distress around easy access to fentanyl, and I will leave it to my law enforcement colleagues to discuss responses. What I do know is adequately resourcing and working across systems to provide strong health responses has got to be a major part of the response. And I know you're seeing in the ICU and in emergency departments, and our EMS colleagues are really seeing the very distressing consequences of fentanyl causing overdoses in our city.
In the back? Nice and loud, please.
I'll see what I can do. So the programs that you're talking about, the services that are provided are split between the Department of Public Health, offering them directly, and a network of nonprofit contractors. And I am the union negotiator for both sides of that. And so one of the things that we see is that there's a labor problem, which is that every nonprofit provided service that you mentioned, Hummingbird, respite, the residential facilities, all of them currently cannot, as today, they're all understaffed. And they're all understaffed because they pay about half what the city pays for comparable jobs. And so they can't recruit or retain. They have huge vacancy rates, super high turnover. And the piece that most people don't know is that the nonprofit service provider population is also disproportionately Black, also disproportionately from San Francisco, and also disproportionately coming from the communities that they're trying to serve. So there's no way to hit these service targets without addressing the systemic underpayment of nonprofit workers who have to deliver the services. And so I wonder I haven't heard that much about where that is in the conversation, particularly on the role of the
So the question for everyone on Zoom is just, thank you, talking about the labor shortage and how that impacts particularly the nonprofit partners and ultimately the service that the city is striving to provide.
Yeah, thank you for that comment and question. And I know, let me answer in two ways. One is without the workforce challenges, not even before getting to the salary differentials that you're describing are huge. So we are working on in the health department, and we should and need to do more, is developing a workforce pipeline to make jobs in behavioral health attractive and well enough compensated to attract enough people to the field to fill up positions as we expand services. This is, in my experience, both a national problem as well as a problem here in this high-cost city. Additionally, it is a problem because, as I think, not you, because you're sitting here, but it is a highly stigmatized profession, and I can share, if I may, my own story, where when I became medical director after graduating residency of a methadone clinic, I was asked numerous times what was wrong with me and why didn't I seek out a more prestigious sort of job. And so I think that experience of choosing to work in this field is, we've got to address that. I think your specific question about the wage differential between city employees and not-for-profits is one that I have heard about numerous times already. And we are looking for, so we agree, and we are looking for solutions to try to fund and support increasing salaries in order to fill vacancies. And as I'm guessing you know, this has serious budget implications, but it is quite pressing. And it is, I completely agree, a matter of racial equity as well. So thank you for raising it.
Any questions? Sir.
Yeah, I'm kind of curious, why can't we do drug testing and like how much fentanyl is in drugs? Maybe have a website where consumers can, can look it up and you have, X amount of fentanyl might be safe if you're this weight or something like that. Why can't this be done?
So, sorry, I'm stepping out of role. So thank you for the question. The gentleman in the front just asked about drug checking as a strategy to decrease a person's risk of overdose, I think is what you were getting at. If you were to obtain a drug, get it tested and see what was in it, that could potentially help a person reduce their risk of overdose or other untoward effect. This is a strategy that is in use in a variety of parts of the world, sometimes in association with supervised or safer consumption spaces, and sometimes in association with some of the party scenes. So we are using a version of that strategy with something called fentanyl test strips. So fentanyl test strips increasingly are being seen as a way to help reduce risk. These are small strips that a person could procure. The syringe exchange programs in San Francisco are able to provide both the strips as well as information about how to use them. Our behavioral health pharmacy is also providing those strips. And so people can test their drug, see if it contains fentanyl, and reduce risk accordingly. It is not foolproof because the story of fentanyl is that it keeps morphing into different what are called analog specific chemical compositions. And so the strips are not perfect at doing that detection, but there is some science and literature showing that it helps people reduce risk and make behavior change to help keep them safer.
Let's take maybe two more questions. So first you, and then you'll be the last question.
Hi. Okay. Hi. I'm a journalist at Wired Magazine. Also, I was a longtime New Yorker, so welcome to the day. But I think one of the biggest differences maybe in some of the areas that I used to hear in New York versus here today is the conversation around tech. And how tech has, made this area incredibly unique. In some cases, tech companies have become something of a scapegoat, or at least discussed illegal exacerbating some of the housing crises and other problems we have here. And I'm kind of wondering when you think about the private sector here in the area, understanding you're coming from the protective of the health, when you think about the role and responsibility of the private sector, how are you thinking about that?
So the question started off talking about tech, but more broadly, how does the director think of the role of the private sector in this issue?
I think you're reflecting on this, San Francisco being a place of great income inequality. And in cities and places where there is great income inequality, we see the kinds of social and health challenges that we're seeing here, where one zip code has a mortality rate similar to a third world country or a developing country, and another zip code has among the longest longevity in the world. And I think we need to acknowledge that wealth and one zip code really does drive a lot of health outcomes, and we need a variety of approaches to tackle that, including, and I think this is what you are asking, is what should be not just behavioral health, but government's role and interaction with private sector and companies that themselves have workforces, that themselves contribute to the environment of a place, and are part of our community. And I would just offer we should be interacting and offering solutions together and collaborating.
I live in a center point, it's around me a lot. I've got neighbors who have died because criminals in their cocaine, they're like, otherwise normal people, when they go out, die, I give out later. Dealers are aggressively asking me to identity by stopping, sell drugs, running. And I know you got this sort of earlier, law enforcement, you're not law enforcement. Curious, like, do you think part of the success would be like, when I see the clutches of the dealers around, like the other half.
Yeah, I'll, do you want to repeat his?
So I think if I heard correctly, the question is another marker of success at the supply side economics sort of argument, like decreasing the demand and thereby reducing the incentive for the dealers.
Yeah, so I think part of our success on the public, my success and our success on the public health side is indeed reducing demand. And it is by doing a package of things, it's not just one thing, a package of things that both directly address a person's substance use or potential future substance use, as well as all the structural drivers of a person arriving at that addiction. Housing stability, poverty, trauma. So that it needs, in my view, needs to be thought of as really a package that reduces demand. And you're using, I think, a term that worth the audience knowing, sort of demand side solutions. Those are often the public health or health-oriented ones, as well as the supply side, often, or the law enforcement or interdiction side. So I think that's what you were getting at, and thanks for that.
Well, guys, thank you all so much. Let's give a round of applause. Thank you so much. And just to reiterate before we transition, as Manny mentioned, this conversation tonight and all of the events that happen in our space are made possible through the support of sponsors. So if you would like to be a sponsor, sign up today, please see any one of us. Brand, if you raise your hand. Brand is our operations manager, tech guru. Tomas is in the space, he's our researcher. Kojin there is our events assistant. Of course, we have Manny or myself. Thank you all so much. And one last thing, mark your calendars for Saturday, November 6th. We are celebrating our 3rd anniversary with the Keep It Blue in 2022 Carnival. We are very excited. We are motivated, and we are going to get that. We're going to keep that Congress and make some amazing change. Thank you all so much. Have a great night.
Thank you.